Welcome everyone to the live case lecture 6, Complex PCI. I'm Alan Yeung together with Adrian Benning here as moderators, and we have a group of esteemed panelists. We have Dr. Tsuda, Dr. Suesat, Dr. Chen, I don't have the name anymore, Dr. Lee, and Dr. Shin, Dr. Suwat, and I think Dr. Tsuda, and Basavarajaiah, I think. So hi, Dr. Wu, it's Alan Yeung here, long time no see, how are you doing?
Thank you. So it's a long time. Yeah. So and the first of all, so the thanks, Professor Adrian and all the friends in the panelists. So and so we are very happy to have the lab demo this afternoon to TCTAP. So here on behalf of the Professor Gao, just deliver the greetings from Professor Gao to TCT. AP organization. And so the last years, so many thanks to TCT AP because every year we join the TCT AP. So this is very important event in the Asia countries. And so this year, and Fuwai Hospital, we have the lab demo. The one from the Professor Zhang Hongliang and another from the Professor Kefei. And both of cases are the coronary interventions. And so maybe first we let the Dr. Adrian and to tell us the basic information about this case.
So Dr. Wu, maybe you can tell us how many cases PCI are you doing a year in Fuwai now? Is it 20,000 yet?
So I think everybody is interested in the volume of the PCI in China, the different medical the centers. So before COVID-19, so the volume of PCI in Fuwai Hospital so increased year by year. So increased by the 10 to 15% year by year. And during the COVID-19, so the total volume is decreased. But last year, that means that after the COVID-19, so in Fuwai Hospital, the volume of PCI is the 22,000. Yeah. So it's a big increase, but I think this year maybe it's more the patient who received the PCI. So I also would tell all the friends, so actually, so after the COVID-19, so many the medical centers, their volume PCI is more than 10,000. So this is,
yes.
And last year, the whole China is nearly the 200,000. Yeah, so it's really so I think next because that compared to the last years in Fuwai Hospital, so nearly more than 18% of PCI is complex. Yeah, so this is because the most of the patients transfer from other province. Yeah.
I'm sure your staff is quite busy and tired. All the 22,000 PCI a year. So go ahead and you're going to tell us about your case.
Okay. Yeah. Dr. Please.
Good afternoon, professors. I will give the briefing of lab case from Fuwai Hospital. The male patient is 14 years old. He has the angina pectoris for half years, and 2 weeks ago he was diagnosed not STEMI, and the CEG has performed 1 week ago. The CEG shows the 3 vessel lesions, and the RCA is CTO. The past medical history is he has no the past medical history. Next. He was diagnosed diabetes for 1 month, and he has the hypertension. No invasive studies. Echocardiograph shows the LVEF is 55% and no abnormal valve movement. Laboratory examinations shows he has the higher SBAC. This is the ECG, shows the leader of the 3 and EVF has the abnormal Q waves. This is the CEG.
Okay, so the proximal RAD, the lesion, so yeah, the circumflex, the middle, the circumflex is also some disease. And the very distal is subtotal closing. So from this view, so we can see the distal RC is from the septal channel from left side. So the right coronary is total closing in the middle. Okay, so here we measure the lesion in the proximal RAD. So we use the KRFI to measure this lesion. So KRFI is the 1.74. So it's the less than 40. Next. So now in Fuwai Hospital, maybe in most of the Chinese the medical centers, so KRFI is very commonly used. Yeah. So the back a little bit. So the back to the CT. No, it's the 回放一张. Yes, 再上一张. Yeah, so here, so just before the procedure, so the patient take the CT scanning. So the CT, the scanning, so CT showing also the proximal to middle segment of RC is the total closing, but it's in the CT in the CT lesion body, so also very calcified. Yeah, the lesions, the lungs. Maybe it's more than the 20 millimeter. Okay, next. So in this case, and because this the lesion, the CT lesion is very common, it's very routine the work for I think for most of operators. But today for the lab demo, so we try maybe it's the first we try the antigrade and. In field, so maybe we can try with the stingray because because the distal RC and so the diameter is not enough. It's very clear. So maybe if the Y in the subintimal, so maybe we also can try the stingray. And next, so and. I wonder because another CTO and compared to last year's CTO technique is so it's very established. But for the younger operators, so maybe they have time to practice. But for the most of the operators, so this is the very routine work. But today, and I think it's the other panelists. So, other panelists, so it's a lot more experiments about CTO opening. So, and I want to know and the strategies from a panelist. Yeah. Okay, so Professor Alayang. Yeah.
Yep. So maybe panelist. I presume the left system. Everybody thought it was moderate. I guess they use angio-based FFR, and it's about 0.74. So. Maybe need to be treated as well. What do people think? You know, the LAD, the circumflex seems diffuse disease.
Diffuse, yeah.
So obviously, you know, the right coronary probably is the culprit with normal, you know, LV function. What do you think in terms of the approach to the CTO?
The CTO obviously is the culprit. I agree with you. But before that, the LAD QFR is probably difficult to analyze now because it feeds a huge collaterals to the right. So if you open the right and then reassess the LAD, then maybe you get a genuinely whether it's significant or not. Right. But in regards to CTO, the cap is very blunt. It's a good case for ADR, but personally, I would scratch the cap because a lot of the time you will surprise that it does catch and you can just do anti-grade wire escalation, or even you do IVAS guided entry into the proximal cap. And if that's not working, then I think about ADR or like modifying the proximal cap using a base or going retrograde.
Yeah, I'm not sure, Dr. Wu, your QFR software allows you to correct for totally occluded right coronary, because most of the like calf works and so forth doesn't ask that question, I don't think.
Yeah.
So obviously here, 0.74 could be less if you once you open up the right coronary.
Although that's a theoretical concern, in a guy of this age, I think that LAD is probably going to need treating, but the key thing from a symptomatic perspective is to get the right coronary open. The history is short, the occlusion is long, the cap is somewhat ambiguous, but we have experts in the room, so we look forward to seeing what they can do.
So go ahead, Dr. Wu, what we've done,
Yeah, I totally agree with the strategies from the panelists. I think this is the quite young patient. It's only the 44 years old. So I think although the syntax, the score is more than the 33. So, and according to the guidelines, so maybe the patient should receive the bypass, but it's relatively young. And so I think he should receive we should try the PCI the first. And regarding to the lesion, the RAD, so although the KFR is 1.774, but I think because the lot for the channel and from the RAD to the right corner, so I'm sure after the opening of the CTO lesion, so RAD, so QRF with RAD should be maybe the more than 1.8. But if anti-grade warning is failed, so sometimes we should try the retrograde warning. And because the left, the lesion, the proximal RAD maybe is influence the anti-grade, the blood flow in the anti-grade. So depends on the manipulation, depends on the anti-grade warning success or not. If it's if the anti-grade warning is failed, so maybe we can try first the RAD stating after that, so we can try the anti-grade retrograde warning. This should be the safer. And so maybe the Professor Zhang Hongliang can talk about his the procedure before the last demo. Yeah.
Okay. Yeah. Dear moderators, dear all the panelists and live audience and fellows online. Yeah, I'm Zhang Hongliang, also team member of Dr. Wu. This is my second time to show the live case to TCTAP. It's my great honor. For this patient, we just asked his history. About 10 years ago, he once had a severe chest pain. The pain lasted for about 2 or 3 months. Also, this patient had ACS 2 weeks ago during exercise, but the TNI is elevated only a little. Also, the ECG didn't show any dynamic change. So we believe the right coronary artery lesion is a CTO lesions. For this patient, we should do revascularization. Cabbage is not the first choice because he is so young. So we decided to do PCI. For CTO PCI or antegrade wire or retrograde, for this patient, we can show the bilateral angiography.
Next.
We can see the right coronary artery is occluded from the first curve to the second curve. Also, the collateral branch from the distal segment of LAD. For retrograde wire, it's a little different to the retrograde PCI. So we decided to perform antegrade wiring.
Next.
Yeah. First, we selected right femoral artery for implants D.5 from the right femoral artery, and the The entry point is blunted. Also, the entry point is very tough. First, we choose the UB3 guide wire to penetrate the cap. But we can see the cap is very tough. The wire always goes to the branch. So we changed another UB3 guide wire for a larger curve. Fortunately, the UB3 guide wire entries into the cap. But as the wire goes, the guide wire didn't have enough spot, and the guide wire dumped out. So we changed to 7 French N+1 to support the strength. Very fortunately, the wire runs to the distal branch at the second curve. We can show from the video. Next.
And what microcatheter do you have in there? Is it a Corsair? What do you have in?
This is a domestic
It's the logo.
APT caster.
APT is a company, so from the ADP company. It's located in the Hunan province. So, and recent years, so this company developed a lot for the devices for the PCI and also for the structure intervention.
Yeah, it looks like Corsair. This shows the guide wire enters into the distal branch.
And is this the ultimate bros 3?
Is
Ultimate bros 3, the wire?
Ultimate Bro, yeah.
Okay.
Yeah.
UB3, right?
Yeah, UB3.
Yeah.
This is the UB3 wire enters into the distal branch.
So I think it's the first choice of the wine, and Professor Zhang and he select the UB3 because this is the favorite. So in our team, so and because from the CT scanning, so it's longer CTO segment. It's also the cap, and very near proximal is catified. So and he selects the UB3 as is the first wine to try. So it looks
Yeah.
in the small branch
Yeah,
distal.
is it an acute marginal branch or something? Yeah. Now you corrected it.
Yeah, as the wire goes into the distal branch, so we pulled back the wire. That turns the head to the main vessel. The wire goes to the main vessel, fortunately. Yeah. From the CT scan, we can see that the occluring segment, there are some calcified lesions. So the camp and the body of the occluring, the resistance is very large. We can see that the microcatheter cannot pass through the occluring segment.
So check the distal.
Next. We checked the wire in the true lumen from
Yeah,
two
looks
angles.
reasonable.
Yeah.
Then we push the wire into the distal segment. As long as the wire goes so far, we can see the microcatheter can also not pass through into the camp. Yeah. Then we use the Godzilla extending catheter to add the support. Then use the 1.0 balloon to dilate the occluring segment.
So what's this? The balloon?
Yeah, this is the 1.0 balloon.
Okay. So you have a guideliner and a 1.0 balloon.
Yeah.
Yeah. Then after 1.0, we selected 1.5 balloons to further dilate. Then we changed the UB3 wire into the workhorse guide wire.
Sometimes if you have a conus branch, you could just anchor a balloon, which kind of gives you more support to spin the Corsair.
Yeah.
But this is also
Yeah. Yes, good idea. So because the very proximal, the branch can be used for the anchoring.
Sure.
But it's so it's a good idea. But it's Dr. Zhang and he tried the Godzilla to support the backup, and so it's finally it's the success.
I mean, top quality microcatheter is very important, right? Because not every microcatheter is the same, and we have used a fair amount of turnpike nowadays, and I think, when the sort of a fibrotic proximal cap, you probably need something strong.
Sometimes we in the CTO cases, so although the wiring in the distal, the CTO body, but it's very difficult. Although we use the anchoring, we use the different the method, it's very difficult. So sometimes finally we use the laser, and try to open the CTO. So maybe this is the last step.
Yeah.
But I think they have demonstrated so nicely the proximal cap, how they handled it. So scratched it and it got in. So I think it's amazing technique we used because, we didn't have to use IVS guided or base or retrograde. Amazingly done, crossing the wire.
I mean,
thank you.
I mean, the JCTO score in terms of, obviously is 3 above, but he's young. So at least hopefully these things are not around for a long time, so you have a better shot at, anti-grade and so forth, because...
So the Zhang still had a long time, and so it's because they use the 2 wine, and how long time to take to cross the CTO lesion?
About 40 minutes.
40 minutes,
Yeah.
so it's okay. And so after the opening of the RCA's the CTO, and we will take the angiography in the left coronary, and we will check from the left coronary angiography, we will check QRFR. So now we
Now we go on to dilate the lesions.
Yeah.
After balloon dilation, we use IVS to check the CTO.
So IVS already prepared.
Yeah, it's good to IVS it to see how long and how much distal disease and whether you're going to be just stenting or you're going to be stents plus DCB or combination.
And particularly when it's been so difficult to cross, whether you need some adjunctive technology in that proximal segment.
Yeah.
There is some calcium, isn't there, you see on the angiogram. Didn't see a huge amount on the CT, but...
Indeed, and this for a young person, I would probably use gold standard FFR to check the LAD and the circ, because the QFR, all that is an easy way, a surrogate way, but if you don't get good views.
Certainly for the LAD, I think the circ should be left alone, honestly. It looks very diffuse, and if you get this right open, and you are confident about the LAD, then you've done a great job.
Right. Yeah. I mean, he has a lot of risk factors, so those are the key for the future. If he doesn't get it, stop smoking and get his lipids in order, this is just the first stage of many intervention, unfortunately.
Okay. So so by the way, I would tell all the friends. So for this patient, so the IRAD is higher. So because before he diagnosed with the coronary heart disease, so have never take some drug to lowering the RAD. So maybe if after opening the CTO in right coronary, if the QRFR in RAD is more than the 0.8, so and after the aggressive lowering the RAD, maybe the lesion in the RD maybe in the future is regress. Yeah, we hope so. But today It depends on the QRF value after opening the CTO.
There's a lot of plaque, isn't it? It's a 4
Yeah, a lot of
vessel,
plaque.
huge vessel, or it was.
Yeah, yeah.
It's
Also, you can
completely
see the
filled with plaque
classification.
all the way down.
I think there's some calcium at the proximal segment,
Yeah.
isn't it?
Yeah.
And it's diffusely diseased. And it's
The
almost
superficial
detailed.
is not too bad. A lot of the calcium is deep, isn't it? And it should probably expand, I would have thought.
Probably
The guiding
iris in the circumflex will look similar
guiding.
in terms of
Yeah.
the plaque burden quite a bit.
I'm not sure I want to see the ibis.
And I don't want to see it. You know.
All of the wires in the true lumen, right?
Look like
Yeah,
it.
it looks like
Yeah,
it's
looks
true.
like it,
It's a
yeah.
true to true.
Yeah, I have a question, sir. You first choice wire choice was UB3, right? So, what kind of factors do you choose between the field XDA or UB3?
Okay, so very proximal. It's very large. So,
Yeah, the orifice
Okay,
is okay.
yeah.
You know.
okay. So, can you show us the distal RC, what's the size? 那个放到远端看参考内径。So the some the natural,
Yeah.
from the natural, please.
So would everyone put, I mean, the CTO section will get a stent, and then the rest, more stents, DCB? What do people feel like?
Yeah, I think it's
The
very
retrograde,
common
the
to see this.
distal vessel looked pretty good, didn't it?
Yes, I think it's
Retrograde
very,
looks good, but
Yeah.
IBIS doesn't look good.
No.
from retrograde. I think we can able to see the size of the at least PTAs at least 2.5 and very proximally probably 3.0, 3.5 and above. It's not uncommon to see this shrinkage of vessels, despite you recently opened up the vessel. So very likely we need to stand the CTO part, but very likely distalized balloon or at most DCB don't put too long. Since too young, 41 years old,
Yeah.
diffuse prevent disease.
Yeah. For the younger patient, so and the wristlet, so we use the DCB the more the
Yeah, I think it'd be a shame to put
Okay, yeah,
70, 80
okay.
mils of
or a slide
stent into this.
injection. Okay, so this is the after the natural. So
Yeah.
I think the distal the diameter, the 2.5 maybe.
I think if you're using
But
these,
you know the PRA is also large. I think it's very diffused. So the lesion extend to the distal, but it's blown and we just want to put the stent in the CQ segment. It's okay.
I think if you're using a DCBR, you have to prepare the lesion more. This needs
Yeah.
a longer NC or a semi-compliant with a longer inflation, and then decide. I think it's for stent it's okay, but for DCB you need to prepare a bit more.
Yeah, right. So I think it's for DCB, so maybe 2.75 or 3.0.
Yes, I
So-
totally agree. And this patient is quite young, 41. And
Yeah.
CTO is one of the best target lesion for DCB treatment. And I think in the IBUS shows that is all true lumen. So, and after the optimal size, the predilation with the non-compliant balloon or scoring balloon, and after that, the balloon angioplasty is quite good. And I mean, this region is already CTO region. So we already achieved the revascularization perfectly. Even though this pre-balloon is quite small, 2.5 millimeter. So and after more larger optimal pre-balloon angioplasty, after that the TIMI flow, normal flow or residual diameter stenosis is less than 30%, I think a DCB only treatment is enough for this patient.
Yeah, thank you. So I agree with you. So in Fuwai Hospital, so the last years we have already finished the small trial. So for the CTO with the DCB, but it's not. It's still on the process on follow-up. So maybe this year or next year we will have the result. But I think after the 2.5 blown dilation, so it's good. So we will use the big blown, maybe the 2.75. And according so we read 放一下这个iris. So now we review the iris again, and we will select the balloon size to dilate. So I think now it's big enough. So we'll use the 3.0. Okay.
Yes, I agree. 3.0.
Okay. 来拿一个3.0的球囊。
Did we see the crux on the IVUS? I'm not sure I did.
No,
But
I think it's a little short of it.
yeah, 'cause I think that's probably, if you're going to stent it, which I would, my temptation would be to go from the crux back,
Yeah.
but not go beyond the crux.
Yeah. I think just proximal to the PDA and then all the way back to, if you want to do DCB, would you just treat a proximal long stent covering the CTO and then maybe a DCB after preparation? Or split
So
into
I
two?
think we need to do more preparation and then decide.
Yeah.
And maybe I covered the CTO segment with a short stent. The problem with the stent here is that the vessel is significantly underfilled. This vessel will grow. I think this vessel is at least 3, 5, or 4, or even at the crux. So if you put a 2.5 stent, I think this patient needs to come back for optimization.
Oh, yeah, nobody's going to put a 2.5 stent in, no other. I mean, we can see there's a massive amount of plaque. This is a big vessel, and I think with stents optimized, you can get a nice result here. I'm not sure about the logic of that segment from stent to crux with DCB. And where's the downside of just extending the stent a little bit?
I mean, difficulty is that if you put a bigger 3.5 stent proximally, you would end up with sort of a cutoff because it's not growing enough yet, and then you look terrible. And I think you end up probably putting too long stents in.
And there is the risk of reduction in flow. I think that's right.
Certainly, optimized stents in the CTO, really well dilated, they do very well. I mean,
I think even if you do put stent in, it's okay because patient will have still graft target because you're not stenting into the PDA. So you're okay, even if it restenosis, you can have. It's not like LAD. Right. So you can do stents. But my only concern is, Adrian, would you bring this patient back for an optimization because that vessel, I don't think they'll put 3-5 stent distally.
Yeah.
Don't worry, we have very nice drug stent. So we can just postpone the final device after optimal lesion preparation.
Yeah, that's why going past this crux a little bit and see what the size is, it would be nice to find an area that doesn't have much plaque to be your anchor.
I also think for these young guys, trying to get them fixed and not bring them back is quite enough. Psychologically, these people don't want to be in and out of hospital. They want to get back to work and their lives. And 3 or 4 trips to the cath lab is not good for their heads, I don't think.
So for DCB, the predilation, and if we use the special the blown, so this blown is not cutting blown. So I would share my experiments with the DCB preparation. So normally we dilate very slowly and deflation is also very slowly. So they try to decrease the dissection. And so maybe we can check with the iris again.
Okay.
Yeah.
Yeah, I think sometimes when we are doing lots of these CTOs, a good lesion preparation and then a lot of nitro weight did help to grow the size. You should out size. I think judging from the PDA and PL size, I think distal right at least will be 3.0 and then go up to 3.5 or 4. But just I think this vessel is still shrinkage, did not dilate enough. You do more good lesion preparation above already, and then give some more nitro. I think the blood pressure well tolerated, and again you give lots of
3, 4, 5.
yeah, something like
At
that.
least 4, 4.5 in terms of the vessel size.
But this IVUS shows that very attenuated plaque inside the CTO segment. So that a little bit large size of the DS is a risk of the through flow or no flow phenomenon after the DS implantation. So that the not so large stent is recommended in this kind of situation, I think.
So now we check with the IRIS again and to decide it. So stent or DCB.
Maybe
Okay,
go a
yeah.
little bit further in terms of the ultrasound. You
Yeah.
can see the
Okay, yeah,
beyond the crux a little bit and see.
yeah. Okay, 送得远一点。Okay, yeah. More distal. Okay. Distal. Okay, go. Okay. So this the very distal is the beyond the bifurcation. So it's the very distal is the similar. It's the looks the good. So the diameter is the 3.0. Yeah, so more than 3.0. Yeah.
The plaque started
Okay.
already.
Yeah, that's your landing
Yeah.
Just a very long diffuse disease.
Yeah. 不是一看看到哪里了。Yeah. Okay, so now it's up to the distal stipulation. So here is the dilate with the 3.0. Yeah. Okay. 这是一个。The flora not looks very slow.
I'll just start with 3-5 stents and
Yeah.
you can optimize it to 4 approximately if you need to.
So now is the lumen is much bigger after the 3.0 dilation. Yeah.
The dissection.
There's some of the dissection.
1, 2, 3, 4, 5.
Actually,
5.
3. Okay, yeah, here it's not very good. Okay.
Does anybody feel we need more lesion preparation? I mean, the calcium seems quite deep and
Right.
Yeah, so you dilate. So maybe the proximal we use the 3.5.
Yeah.
3.5. 拿一个3.5的那个基突球囊，近端再拿一个3.5的打开。对，3513。So now we use the 3.5 the balloon to dilate the proximal. And we have the several minutes left. So maybe after the predilation, so and the panelists give us the final decision, the stent or the DCB, and then we check. 再回来一点。So we check the RAD verify.
Okay.
Yeah. And we will see the change or not, the clarifying RAD.
Do you want us to go to the other room and come back?
Okay,
Yeah,
good.
so you can have
Okay.
optimization and put stents, and then we can come back to you and
Okay.
see how the result. Is that
Yeah.
okay? Yeah. Okay.
Okay, thank
I'll
you.
see you in a
Thank
bit.
you all
Yeah.
the friends. Okay.
Let's switch to the other room with Dr. Du. Hi, Dr. Du. This is Alan Yeung from TCTAP. So nice to see you. You're concentrating on your case. When you have a moment, can you introduce the team and the case for us?
适应的地方就是这个地方，它俩交汇这个地方。你现在在动逆向正向，我现在动逆向。
I'm not sure they can hear us.
对，把它咬紧紧的嘬到里面的时候，然后从正向传的。
Hello, can you hear us, Dr. Du and Dr. Yin?
Hello?
Yes,
Hello, can you hear us?
hi.
Okay, hi. Hi, good afternoon.
Good afternoon. So we just finished partly with Dr. Wu, so we decided to come over to your lab to take a look how things are going. So maybe you can present, introduce your team and present the case for us.
Okay. Good afternoon, dear friends and colleagues. And it's a great honor to be invited to join TCTAP again. And I'm Dr. Do, and the left side is Dr. Yindong. I also have Dr. Wang and Dr. Zhang here to help us. And today, Dr. Yindong will do the case, and I will be his assistant. First of all, Dr. Yindong will introduce the case, please.
Okay, thank you. I will introduce the patient information. This is a 51-year-old gentleman. Can you hear me?
Can you hear us, Alan?
Yes, I can. Thank you. Yeah, go ahead.
Okay,
yeah.
please go on.
He suffered STEMI 10 years ago and received PCI, and with several stents in left main to LAD, circumflex, and ramus intermediate. He suffered again since last year and underwent coronary angiography 4 months ago at a local hospital, and which shows the situations in RCA and instant CTO in circumflex. The local hospital doctors successfully reopened the circumflex, but failed RCA CTO recognition. 下一张. And his risk factor included hyperlipidemia, no diabetes, no hypertension, and no smoking. Next. 下一张. And the echocardiography shows regional wall movement disorder at normal left ventricle size and function. 下一张. Here is the coronary angiography. There's patent stents in LAD and in circumflex and in ramus intermediates, but long CTO segment from proximal to distal RCA, and there are septal collaterals from left to coronary and coronary. Next. We also perform CTA before the procedure. You can see the CTO segment is very, very, very long, and there's some calcification within CTO segment. The JCTO score is about 3 points. Next. So today we will perform RCA CTO PCR. We will use the hours guided entry point puncture firstly, and then integrate wire escalation. The backup plan is the retrograde wiring, and maybe with the Godzilla facilitated the reverse cut. Right? So the teaching points of this case is how to plan the strategy and when and how to switch the strategy of the CTO PCR. Thank you.
Okay, let me show you the angiography today. Okay, and we can see left side is good. Next. And from cranial view, we can see some collateral from left to right. 下一张. 下一张. Okay. Next. Next. Okay, we can see RC CTO, proximal RC CTO is ambiguous proximal cap. And we use the bilateral radio approach. One is 7 French EBU and 7 French M+. Next.
Perhaps we should take some comments from the panel. I mean, this is tough. Those septal collaterals look like they're coming out of the LED stents. It's long. Sandeep, what do you think?
Yeah, so here again, the cap is quite ambiguous, but I think they're doing IVUS guided puncture. That's amazing. So again, they're scratching the cap with the help of IVUS. But I think there is some antigrade filling as well after the occlusion. And of course, there's retrograde filling. The distal caliber is very small for a ADR. So I think if I were to tackle this, I would go antigrade primarily, maybe wire escalation, parallel wire. If it fails, then I keep the wire, go retrograde, then do a reverse cut.
And how many times out of 10 would you achieve this antigrade lead, do you think?
I mean, the way I look at it is, if you want to go retrograde, you have to do some antigrade work anyway. So you might as well do some work. Who knows, if you are lucky, sometimes you do catch a true lumen. And if not, you can keep the wire because you've done the antigrade work. Then you go retrograde, and then you connect the spaces because you've done some antigrade work.
Colleague beside you agrees?
Oh, yeah. To me, I was kind of the puncture is very excellent because of ambiguous proximal cap, and there are many collateral, breaching collateral. So I didn't realize that what the proximal cap is. So, yeah. And the retrograde approach would be very good option because it is very tortuous and a long lesion and double CTO lesion, I think. So retrograde approach would be acceptable.
The colleague at the end?
Yeah, I would agree with what has been said. Maybe the only thing to add is to maybe better understand whether any of the other septals are supplying good collaterals is to maybe put a microcatheter down the LAD and take some selective injections that way to see if there are any better channels.
What wire are you using to do the integrate wire escalation? What wire do you have now?
Asking me?
Sorry. What wire are you using?
I think Dr. Indung will show you what he did just now.
Okay.
Please,
at first we do the iris evaluation, the entry point.
Please put iris on screen.
Iris?
Iris, please, on screen.
Actually, unfortunately, the branch, the angle between the branch and the main branch, side branch and the main branch is very big. So we can see much more information of the entry point. Can you see the iris?
Yeah.
Yeah, so the angle is very huge, around 90 degrees, so not very clear. I think Dr. Indong just now failed use the antigrade wire puncture the proximal cap. It's in the wrong place. Next, please.
We can't see the iris.
We use UB3 wire to puncture the entry point and go further the wire. And we check the entry point used with the iris, round two.
对，可以了，第二个 run. Okay. It's not that clear, I think.
Do you have IVUS image to show us? Or? Yeah, we don't see any IVUS, which is...
Maybe it's in the structure, but
when
it goes further, I think not very well placed. Next.
But in this view, the course looks okay, but we have to check in the RAO view, which, I think it's gone off track.
Yeah, we checked the RAO view and do the left side injection and can't make sure it's in right place. And then Dr. Indong decided to go retrograde. The reason is because the CTO segment is long and tortuous, so the parallel wire or the AWE success rate is not that high. 你讲一下那个逆向。Okay. Please.
Yeah, we use a domestic microcatheter. It's a APT company. It's a 1.7 French, like a fun clause.
Next.
And we use a SUS 03. And
you have a sewer wire, yeah. Mm-hmm.
Yeah, sewer 3, yeah. Next.
And you have a dual lumen catheter there to help you anchor.
So in this particular case, I think we have dealing with an extremely long plus CTO. So I think the key point is make it safe and efficient. So most of the time we want to keep the wire inside the intravascular, inside the vessel architecture.
Yeah, agree.
So very likely need the retrograde, of course. So then it depends on how long two wires get met. Very likely we then follow with, for example, subminimal tracking and then bilateral knuckle and then make the connection somewhere in case the retrograde wiring fails, because we still do a long plus CTO with ambiguous course over there.
Yeah, I totally agree. And this is the retrograde injection from microcatheter. You can see the distal cap. And maybe we have a stamp to puncture. And the first, I agree what you said just now. For safety, we usually use Pella 200 or knuckle technique to make it sure the wire is in the structure. Next. And Dr. Yeung used the retrograde Pella 200, and it's not easy to cross the distal cap. And then UB3, and he feel the UB3 across the distal cap, then change to Pella 200 again. Next, please. Next. It's the 200, Pella 200, right?
Yeah, 200.
Finally, we found it seems like the antegrade wire and the retrograde wire, they are all in the structure, but the distance is a little bit big.
Yeah, it's very far away.
So, so of course we can do do reverse cut like this, but the success rate is not very high. Next. So we use the double lumen catheter and use another Pella 200 and try to make the second Pella 200 go very near to the retrograde wire. Next.
That's amazing.
And then we found at this point, I think we met a very hard plaque, and at the angulated portion. The retrograde wire and the antegrade wire can't cross this point. So if we can cross this point, and the reverse cut will be very easy. This is where we are now, and I would like to hear your suggestion.
So I think you're facing the very strong resistance point over the mid-right, right? And the antegrade and retrograde wire really can go even further. And you can see the guidings are kicking out because of a strong resistance of the mid-right. So very likely, I think you already make a good track over the distal and securing the distal and distal right. And at the end of the day, I think you need to stand all the way from proximal to distal. So no matter what you do from antegrade wiring, this didn't really do harm. So probably you can knuckle the antegrade wire further down to gain you more support, and then you can do ballooning together with guide extensions. And to facilitate your reverse cut over there. Probably there's a strong calcification over the mid-right. So you cannot break the further advance the antegrade wire further to make you more support for the antegrade balloon, then probably will get stuck over there.
Yes, I agree. That's one of the options. I think we can knuckle down and strengthen the spot, bring Gazetta in, but if we knuckle antegrade wire, I think it definitely go to the subintimal space, and it will be a little bit far from the retrograde wire. Of course, we can try a reverse cut, but usually what we do is to use an harder wire. Now the antegrade wire is CP. Dr. Yeung use CP to puncture the retrograde wire. If we cross this hard part, and I think the two wire will be very close, and it's easy to do the reverse cut. That's our way to handle this type of situation.
I think the other option is, yes, you can do the knuckling as suggested. The other option is to bring the microcatheter more, the retrograde microcatheter more, and maybe try Gaia 3 or a Confianza, because you may do a retrograde wire escalation into the true lumen and the proximal segment. If that doesn't work, then yes, you knuckle down and then do a reverse cut.
Yeah. You mean we can use a stiffer retrograde wire to puncture this part, or?
Yeah, I think we could try maybe Gaia 3 or a comprehensive, maybe Gaia
Yeah,
3
yeah.
might be-
That's our next step.
Yeah, so
And
that-
it seems like the two wire is very close.
yeah.
Yeah?
Yeah. And you also got an
So,
aim.
Dr. Yindong, you use a CPR just now. You feel you puncture something or cross something?
Yeah, a little. Now I downstage to the part 200.
Yeah. And for safety, he changed CP to 200. And if the two wire is very close, I think he will start a reverse cut, right?
Yeah.
Yes. I think the position is better than just now. Do you think you need another view?
Yeah.
准备改这了 okay. Yeah, that's very close, I think. Go further, I think we enhance the support and we start reverse cut. Okay. Okay. I think this is the right place to do reverse cut, and the success rate will be very high. 209呢？209产品不拢。
I think we should check orthogonal view.
To dilate the
Okay,
this
okay.
CTO segment to use
Okay.
the cosell.
Okay. You can dilate it, and it will be easier to.
I think you can check the orthogonal view, but I think the wires are very close. They're dancing together. So
I think they're pretty
very
close.
likely 2 millimeter
Yeah.
balloon may just connect them.
So because this red corner is very huge, so I think the two are all in the plaque. We can prove it by hours later. So Dr. Yindong is a little bit slower than before, huh? Because I'm not a good assistant. Okay. 是的，16。啊，我撤掉了。我觉得你把那个也拔掉。You can choose another wire, I think. Brazilian, please. And check the two balloon ready. So do you think we do it easy?
Yeah, maybe that's what we should do.
Two balloon, please.
Dr. Yin and Dr. Do you want us to go to the other room, take a look what Dr. Wu is doing while you kind of try to see whether this,
Okay,
and
okay.
then we can come
I'll
back to
tell
you.
you what happened.
Yeah, yeah, thank you.
Okay.
Let's switch to the other cath lab and check with Dr. Wu. Can we switch to the other cath lab?
I agree.
Okay. Okay, thank you. A minute. Oh. We can just keep watching for a little bit because there's some problem in terms of
Yeah, I think
transmission.
the strategy he's using now is very recommended nowadays. To upfront using a guide extension to facilitate, first of all, the balloon to pass down the very stenotic calcified proximal cap, together with facilitate reverse cut all the ways because of the turn outside. Lots of when you go to the upper part of the outside, when you make a turn, always have difficulty enter the anti-gate guide. Yeah, and the guide extension is always strengthen the case and make it more simple.
Wire 再远一点。
So there's some problem with the other lab, so we're going to stay here, Dr. Do and Dr. Yin.
No hurry.
So,
You've already success.
so we have
Is that other people's experiences that perhaps we may be better more proximal or more distal, and that this is kind of more difficult at this point?
You mean the reverse cut?
Yeah.
Yeah, no, I think they're trying to get the guideliner down with ballooning, and then after that they could probably do the reverse cut in the mid-segment. So, yeah, I think that's probably their aim. If not, they have to come down further down, maybe
It's not easy.
Where the C-bend is.
Usually the best spot is where the wire, two wires cross each others, and that's the spot where likely they're the same place. They like a little bit further down and then change the, just deflate the balloon and then use the retrograde wire, more penetration, then puncture up usually will do the job.
So maybe 15 mils on from where
a little
the
bit lower.
marker is there?
Yeah, a little bit.
Yeah.
You can see the wire.
Get that wire on a bit.
就是那个 hard place.
Just want to know what is the retrograde wire now? What is the
那个1.5的 new one 吧，好不好？啊，1.5的新球囊来。
What retrograde wire are you using now?
The retrograde wire.
The other thing, I don't know whether if they take a Gaia 3 from the retrograde, it may just go into the antigrade guideliner.
Okay. Is it in I think it's part 200, right? Adam, are you here?
Yes, we are here. We couldn't go to the other room, so we stay with you.
And when we do the reverse cut, I think it's lucky we found the antigrade wire, the part 200, go easily down to the distal cut. We can see whether it is.
It went through.
Can you see that?
Yeah, I can see the pilot 200 tracking through.
Maybe.
Yeah, and it went to the PLV branch, maybe?
I do the red.
Or somewhere else.
Yeah, sometimes they break too early for this scenario.
When it goes too well, sometimes it's also not so well.
Yeah. I think it's in Truman.
Yeah.
I think your retrograde wire helped to aim the antigrade.
You can try, Doctor.
But sometimes it's because it's a pilot, it's all go to the subminimal plane so easily.
Yeah, especially pilot.
Together we already crossed the
pilot
retrograde.
200 is a go everywhere wire, so it's a little.
Some staining there, right?
Not sure. Maybe a retrograde injection maybe help you sort of see where the path is on the.
Okay, let's take a picture. Take a picture.
And maybe while you're taking a picture, you can wiggle the wire and see whether that actually goes into anywhere.
Yeah.
There's really not a whole lot of PLV there. There's another occlusion there.
And I think you can try. You want to go to the PD or I can give you a talk to.
There's a little staining in the apex there.
It's a very severe stenosis at the ostium of PDA. So there's some staining.
I don't think so.
But the staining stays there, didn't go, so likely a contained hematoma or something like that. I don't know, maybe from the RAO.
I think the right way is to do
retrograde is that it's really kind of a very acute angle.
1.5吧，好不好？
The wire sort of has
1.5的 new balloon.
getting a little cheese cutting there.
Yes, I think.
This is a more middle proximal, more gentle curve. This is like an acute turnaround.
Yeah.
再远。过不去了。
So I think we can go to the other lab now.
Okay.
So we'll leave you guys to do some work, and it's great to be back in the other lab.
Go to the other room.
Okay.
We see you on the screen.
Okay, Dr. Wu and Dr. Zhang, we're back to you in room 1, so tell us what you've done.
Okay,
So we were here, you were doing more dilation, preparing, and deciding whether you're going to, what stents you're going to put in. And
so
Dr. Wu is unscrubbed already.
Okay, I'm ready. So, and back. Last.
Okay, so more
Okay,
lesion preparation.
So this is so it's the very slight injection, and we find the dissection in the middle RC, and then we use the 2.5 balloon and to dilate again with longer time, and proximal with the 3.0 to dilate. And after that, we checked with the iris So the sections have to maybe have to stay. So we decided to use the DCB, and in the middle we use the 2.5 by the 13, and approximately 3.0 by the 25. So this is next. Yeah, this is the 2.5 by the 13 next. So this next. Yeah, this is the 3.0 by the 25. So this is the final result. So I think it's acceptable. So we checked with the node view. So the node view is also the dissection a little bit. And do you think it's accepted or not with the DCB?
I think if you go
That's
by
what
the...
he's saying.
Yes, I think it's perfect.
No stent, you mean?
So beautiful
Yeah, no
research.
stent.
I mean, I can understand the logic. He's 41-year-old diabetic, but I think it's slightly controversial to not put stent here. Look, I've DCB'd these kind of arteries, but if you look at, there's some recoil in the mid to distal segment, more than 30% recoil. Either I would correct it or put a short stent. But whether to do the whole DCB is always a controversial when there is no data on large vessels.
I think it's harder, having seen that IVUS, to accept that lumen. You know, the lumen is really quite small, and then there's dissection, and you know that if you put in well-deployed stents, it'll look great. Yeah. It's a huge distal vessel. Why not put some stents in?
And stenting the whole proximal area, it doesn't really jeopardize you for future intervention, such as bypass and so forth. So I think at least stent the area that has the CTO in it.
Yeah, a lot of calcium, fibrotic disease and calcium, I would say.
Okay, we can see the type B dissection. However, the contrast dye is rapidly washed out. That is not flow-limited dissection.
Yeah.
So I think it's very nice result. And I want to one point recommendation or ask, and that is the anti-thrombotic treatment right after DCB treatment. This is a diffuse lung lesion and huge plaque burden. And rarely some thrombotic event is developed right after DCB treatment. So these patients took aspirin or clopidogrel during antiplatelet therapy pre-treatment, right? And however, rarely that is not enough right after DCB treatment. So very short time, I mean 1 or 2 days, we need some anticoagulation treatment. What do you think about?
And what would you use as additional treatment to aspirin and clopidogrel? You mean heparin?
Very rarely. However, if you check the OCT in this case, and very small thrombotic and material is just then attached around the dissection flap. So we need some anticoagulation, very short period. I think in 1 day is enough.
Well, one day you will know whether it stayed open or it hasn't.
There is always, especially in this kind of very long shoes and
a lot of disruption.
Yeah.
There is a lot of disruption.
Yeah. Okay. So I think we because we have already launched the one trial is called stentless. We try to compare the blown strategy and the stent strategy in the de novo lesion. So now we have, originally we will more than 2,700 the patients were selected for the trial. So now we have finished the more than 200 cases. Our previous experiments, so the dissection type B and type C, so we just left alone. And after the procedure, we just use the heparin for 24 hours. So I would like to left alone. So because it's very young, so so now we move to the left side. So here, so after the opening the RCA CTO. So we checked the clarify again in LED. So, and I just asked our technician. He told me so the clarify is the same as before. So although after CTO opening, so I think it's still the 0.74. So, but my strategy, so today is just stop here and maybe in several months we will check. Maybe in the 1 month we will check the RCA, and at that time we do the regulation. So this is our strategy. And any suggestions from the panelists?
So just to summarize, you plan to DEB the right coronary. You've done the QFR of the LED, which remains abnormal. And your plan is to come back in a month and repeat imaging of the right coronary and perhaps move to definitive treatment of the LED. Is that the plan?
Yeah, this is the strategy.
Yeah.
I think I would say 3 months, because you want to see the positive remodeling of the RCA because you've done a DCB. So 1 month might give a sort of early feeling that it may fail and you may end up stenting. So maybe 3 months gives a remodeling, and then at the time it might be good to assess the LED.
Okay.
I know a lot of Chinese patients coming to Beijing for treatment. So if he's local, I think that's reasonable to come back, and there's a lot more work to be done. Look at the little diagonal on the top has a pretty tight lesion as well. So thank you, Dr. Wu and Dr. Zhang, and really for this CTO case, and really illustrates there's a lot of issues that we need to still kind of work out for these long diffuse disease lesions. So thank you for this great case. Thank you.
Okay, thank you. Thank you all the friends. Okay.
See you.
So maybe what we're going to do, Spencer, is go ahead and, I don't know whether the other lab is going to be a while or not, but maybe we'll see how they're doing, and then we decide to go to lecture. So Dr. Du and Dr. Yin, how are things going? I see those staining.
Let me introduce the procedure. And we bring the Gazella down and do reverse start. At first use 2 balloon, but fail. And then use 2.5 balloon. And then use 2.5 balloon. You can see the retrograde UV3 goes into the Gazella successfully. And next. And what we are doing is reverse Wanderoo technique. Usually we don't use UV3 because sometimes it's not easy to bring the retrograde macrocatheter into the Gazella. So we do the rendezvous technique. And you can see the retrograde UV3 and goes into the antegrade corsair successfully. And what we want to do now is to push the corsair down to the distal true lumen. And in this, at this time, we need to retrieve retrograde. You can see Dr. Indong is retrieving the retrograde macrocatheter. And we can push the antegrade corsair very easy, go to the distal true lumen.
Great.
Okay. So next we will change to workhorse wire and dilate the right coronary and then check iris. So 3, please.
Yeah.
Because that stain is staying there, does that make you
staining.
not too worried?
I think the pressure is stable. Maybe it is some collateral injury when we do the retrograde wiring.
I think it's a septal, so probably which is why it's kind of holding up there, the dye, it's not clearing. So it's a good sign that it's just in the septum.
Okay.
So getting rid of all the retrograde gears and proceed with work.
So I think in this case, usually we will first retrieve the retrograde gear. Yeah. But because there is staining there, so I think we will put the retrograde macrocatheter there, just in case. If there's a perforation, we will do some treatment. careful against the.
In the interests of time, it may be sensible for us to take our lecture and come back to you in 10 minutes to see the result.
Okay, okay.
So perhaps I could introduce Spencer King, who needs very little introduction, but he has the provocative title for his lecture, Who Will Treat the Most Complex Patients? No success goes unpunished. Spencer, thank you very much, and we look forward to hearing your views.
I don't know if the Fuwai group planned these two cases to complement my talk, but here we are with, there are multiple ways to go at by the way, do I have controls over here or should I be over there?
I think
it might be.
There's nothing here, okay. This will not be an extensive dissertation, but we do have other ways to treat patients. We have surgery, we have medical therapy and so forth on various patients. And the thing that strikes me recently is that things have changed so much. You can remember times when Andreas Grunzig said, never treat a left main. Now we have S.J. Park in this meeting saying, never operate on the left main. So things evolve, and they evolve for good reasons. But what I'm going to do is tell you that the way it was, the way it used to be, was that when we've had very complex patients, very complex situations, the surgeons would say, this is way too complex. You should never do angioplasty. We should go ahead and do surgery. That's the way it used to be. The way it is now, frequently is that the surgeon says the case is too high risk for surgery. Why don't you, interventional cardiologists, have a shot at it and see if you can fix it? So that's how it's evolved. I'll show you one case, just to illustrate the point. 85-year-old patient with acute syndrome, his ejection fraction is down a bit. He's got some chronic kidney disease, diabetes, hypertension, and lung disease. And has this electrocardiogram on admission with the acute syndrome. And here's the first angiogram. And you see a left main lesion, you see a trifurcation, the disease, you see a subtotal occlusion of all these vessels. You see LAD eventually that will show you that's diffusely diseased as well, some side branches, and the LAD, you see the mid portion of the LAD is also involved. This may dissuade the surgeons to some degree. So this particular patient, and the right is gone, this particular patient, the options are there for various things. What's the treatment going to be? Surgery, PCI, or medical therapy? Well, we talked a lot at this meeting about risk stratification and prediction of what's going to happen. So what is going to happen in these super high risk kind of situations? From the surgery side, this is you got diffuse LAD disease, maybe an internal mammary to the LAD is not optimal. The patient is 85 years old, maybe that's dissuading that approach somewhat. There are important comorbidities. From the PCI side, the patient's situation is complex. There's diffuse calcification, probably need for debulking, maybe rotor ablation, maybe myocardial support will be needed during the procedure. So the decision is in front of us. So you could apply risk scores to this patient, for instance, STS score, and that we did for this one. So we come up with an operative mortality prediction of 7.6. We come up with mortality and various other morbidities of almost 20%. small risk of stroke, some risk of renal failure, prolonged ventilation, prolonged hospitalization. So these are adverse things for surgery, which might influence our decision from the STS scoring, and then you can apply Syntex 2 scoring, and you can project a 4-year mortality, and this was done, and it came out to 28% for PCI, and the same thing for surgery. So things are not looking too rosy with either of these approaches, given these kind of scores, which of course are not necessarily always correct. What was done? Well, what was done was PCI. Patient, because of his age and comorbidity, ends up having a complex procedure and gets a very nice outcome. Initially, the LAD, diffuse disease, is not opened up. But where's the evidence that this is the right thing to do? This patient was turned down for surgery, and there are no randomized trials of surgical turndowns that I can find. Plenty of patients are turned down, but I've seen no randomized trial of that. There is a recent registry of over 700 patients that were surgical turndowns, and PCI was performed, and this is at 20 experienced centers with complex disease in high-risk patients, and so we might take a look and see how that came out. In this registry, the patients were judged to be at prohibitive risk. I use that word, prohibitive risk, for surgery. But how prohibitive was it? The STS score in those 700 patients was 5.3 projected mortality, operative mortality, but they didn't have surgery, they had PCI. And it turns out the actual mortality was 7.6 at 30 days, and the 6-month mortality was 12.3. I'm just showing this to say that from the patient's perspective, who's turned down for surgery, they say it's prohibitive to do surgery, and the patient says, oh, good, you can do something much safer, namely PCI. In this registry, it came out about what you might have predicted if they'd had surgery. What were the reasons for turn down? Well, there were a whole list of reasons. For the sake of time and space, I'll just mention that poor targets were listed in this trial. Systolic dysfunction was listed. Lung disease was listed. What we do is quite counter to what the guidelines say, and that may be appropriate because the guidelines would say a patient like I've just shown you with a very high Syntex score, decreased left ventricular function, that all comes out for surgery. But many of these cases are turned down by surgery because they feel like they're at prohibitive surgical risk. And they are referred to the interventional cardiologist. In this particular registry I showed you of 700 patients, the residual Syntex score, the ones that couldn't have surgery but they had PCI, was 15. You may recall the Syntex trial and the optimal outcome. If you have a Syntex score residual less than 8, you had a pretty good outcome, but above that it was much worse. So many of these cases are not going to achieve complete revascularization or optimal revascularization, but they are very complex and difficult patients that formerly would have been turned down for PCI and might have had surgery, but now are turned down by surgery and are offered to the interventionalist. Well, in that same registry, as I show you at the top, the STS observed to expected mortality rate was dead on equality, the same. Same thing with Euro 2 score. We couldn't prove anything based on that. The patients were better. As you see, the symptomatic improvement occurred in the patients who survived. and was much better than perhaps it would have been if they were left alone or only treated medically. So what does the future hold? Is there any way for us to get a handle on what to do with these kind of patients? Can a randomized trial be done? Is it possible to have equipoise and decide that these so-called surgical turndowns can actually we can investigate, is that the best thing for the patient to go ahead and do PCI? Is there such a thing as futility of some of them, or presented with the outcome of the less invasive approach, the patient might say, well, let's try to do neither for a while. That's some patients that might be correct. Would the results apply broadly to patients or only to very high risk and experienced centers? Most operators, clearly in the United States, do not have experience with these most complex cases. And will the surgeons operate on patients with STS scores above 5 or above 7 or whatever it is? I think local registries are our only approach right now. I think what we need to know is what are our results in such patients who are turned down for surgery? What are our results with PCI? How many of them do we bail out? Should some of them be considered for surgery as well? And are there some of them where futility really reigns and they should have neither? But for you CHIP operators, you high-risk operators, no spectacular success will go unpunished. And the more tough cases you take, the more you will get. And perhaps that's a good thing. Thank you very much.
Predictably, Spencer, that's very provocative and challenging. I would say that I think the dial of the surgical risk for, or surgical appetite for risk, the decline for their appetite was exaggerated by the COVID pandemic. And our surgeons in the UK are now extremely conservative. And to try and persuade them now to take high-risk cases is so difficult, particularly with the advent of TAVR. So perhaps if we could go back to Korea, if that's possible, and see the last few minutes of the case.
Let's do it.
Are you with us?
Yeah.
Yep. Okay,
Dr.
Dr. Zhu and Dr. Yeung, we're back to you.
I will show you the iris, and
okay.
Just as I presumed, the odd wire is in true lumen intraplaque.
Okay.
And put the iris on screen, please. Iris, please.
Yeah. We see it as well.
第三个. Okay, this is in PDA. Dr. Yindong will explain this iris image.
From the distal assay, we can see this severe stenosis, and to the CTO segment, we can see the wire is all in plaques. Here we can see some
negative.
Yeah. Here we can see some hematoma. Maybe the first integrated wire made this hematoma, but at last our wire is all in plaque. Here's some calcification.
And this is where we met a huge difficulty where we use a complex probe to puncture here. So the odd way is in true lumen, and I want to listen to some suggestion. Actually, in PLA, there is still another part of CTO. So we are planning to just put a stent from PD to proximal RCA and leave the PLA CTO and treat it later or just use medication. And I want to listen to your suggestion and show them the this end. Yeah,
The PDA
you
is
can
a
see
pretty
this
big vessel,
angio.
so I think
We
if you
can see
get that fixed,
maybe
at
another
least it's
CTO or,
yeah, you
or
have to work on
very
PLD.
severe stenosis at PL.
Yeah.
Yeah, so if you guys do this case, you will open the PRA simultaneously or just treat PDA today?
It's on your previous shots. It seems like there is a lumen. There's an opening from the P.
Yeah.
Right
Maybe,
coronary.
maybe.
Yeah, maybe fix it and see what you get, and then if it is actually there's a lumen, you can fix it at the same time. Otherwise, you can do it another time.
Okay.
Or leave it alone.
Okay. Okay. I think we will next use double lumen catheter and the workhorse wire to try to negotiate the PL. But if we do that, unfortunately, I can't show you the final result today, maybe.
So, Dr. Du and Dr. Yin, we time's up. So I think please continue, and we might be able to have getting the results of your procedure, and certainly very complex CTO as well, and great job in the retrograde.
Thank you.
Techniques, and then hopefully get your stent done and move on. Thank you very much, and thank you everyone for this session.
Thank you everyone.